I'll talk about the below the clavicle blocks. What I'll do is I'll concentrate on axillary. The reason is, if there are any novices here, those who have not done, then at least they can go and start doing one block. And if you think about which block I should start with, I'll say axillary. For several reasons. Axillary has got the best sort of success to safety profile. So it has got pretty good success rate. At the same time, like the incidence of causing complications is very low. The only thing you need to worry about really is local anesthetic toxicity. Lots of vessels around, so make sure you know the vessels. Don't put your local anesthetic into one of the vessels. That's all you need to be careful about. It's a superficial block, so for purposes of learning ultrasound block, it's very easy. You can see the structures well, you can see the needle well. When you do ultrasound with a typical axillary block with a ultrasound technique, you're blocking about 4 nerves. So just imagine 5 axillary blocks you do, you have done 20 nerve blocks, already up there on your learning curve. So there are several advantages. I'll go through some of the anatomy, and I'm not going to tell you how the nerves run and things like that. What I'm going to do is, all the time we are showing this 2-dimensional images on paper. And we are actually asked to do these blocks on 3-dimensional structures, body structures. I'll try and make you think how that 3-dimensional body gets translated into a 2-dimensional image on the ultrasound monitor. So for axillary block, what you know about anatomy, it runs the brachial plexus, the neurovascular bundle that surrounds the brachial plexus or with the brachial plexus, goes from midpoint of clavicle along a line towards the axillary artery, if you feel that in the axilla. And that's shown here. Can I have the pointer, please? So that's shown here, midpoint of clavicle. Here is in the axilla, you'll feel the axillary artery pulsations, and the whole neuromuscular bundle runs. When you are looking at the surface anatomy, you'll see the biceps in the anterior compartment, triceps in the posterior compartment, and the groove between the two muscle compartments, and that's where the neuromuscular bundle lies. Axillary artery anterior, axillary vein posterior, but you can have more than one vein, and it might be anywhere. The median nerve runs anterior to the artery, and it's superficial. The ulnar nerve runs posterior to the artery and superficial. Musculocutaneous nerve, which has come off at higher up in the axilla, you might not even see it. It has already at that level in the axilla where you block, it's a separate nerve. So that nerve runs between the coracobrachialis muscle and the biceps brachiae muscle, and it's deeper and on the anterior aspect. The radial nerve, which is not seen here, which is behind, is on the posterior aspect and is deep. So a lot of anatomy to just remember. Similarly, like as you go down in the arm, you see that the median nerve runs first anterior to the axillary artery and then medial to the brachial artery, whereas ulnar nerve runs posterior under the medial epicondyle. But really, when you're thinking of these 2-dimensional images, you have to think about the cut section. And that's where you are sort of like geometric orientation. Some are good at it than others. My son is very good at thinking about this sort of like spatial structures, whereas I'm not. But you can learn doing this. So cut sections, if you see this cut section, you know biceps in the anterior compartment, the coracobrachialis there, and then the triceps muscle in the posterior compartment. And this particular space between the two muscle compartments is where we are trying to put the local anesthetic. When we didn't have even nerve stimulators, what we used to do is fill the artery and put local anesthetic just around the artery. Somebody did a calculation of how big is the space, and they said the cylinder is about 6 centimeters long and 3 centimeters in diameter, and that's how they calculated the volume of the cylinder, which is 40 ml, and put 40 ml in that compartment, and you got nerves blocked that way. But here, this is not good enough for us. We have to then translate this into a two-dimensional image. So what we do is put an ultrasound probe there, which then translates this structure, what you see as a rectangular, on the ultrasound image. And if you see here, this is the anterior border, this is the posterior border, this bit on this side is the superficial, which is the medial aspect, or this is the superficial bit, which is the medial aspect, and this is the deep bit, which is this bit. Yeah? So you need to get that orientation, anterior, posterior, medial, lateral or superficial, deep, all that in your mind right. I've seen so many images on Google which say that this is the lateral aspect, but it's not really. In anatomical position is like this. So your biceps comes anterior, not lateral. And if you see that then translated into an ultrasound image, what you do is actually rotate this image 90 degrees to the left. So when you rotate that 90 degrees to the left, what you find that this anterior border is this border. The posterior border here is this border. The superficial is this, and the deep is this. So no, it's the other way around. But here, like actually, if the probe is this side, this is superficial. But when you see on the image, it will actually be 180 degrees, so that the superficial will be top and the deep will be the bottom end. So need to think how actually that cut section is translated into an ultrasound image. And then if you see that you compare that image with the ultrasound image, you know the median nerve is superficial and anterior, which is like, then you relate it to a face of a clock, artery being the clock, you find median nerve between 9 and 12 o'clock. You find ulnar nerve between 12 o'clock and 3 o'clock position. You find radial nerve between 3 o'clock and 6 o'clock position. And median, the musculocutaneous nerve, which has already come off, lies between the coracobrachialis muscle and the biceps brachii muscle. So I said axillary is one of the good blocks to do. You can block nearly 3/4 of the arm with axillary block. And for lower limb, you can do it with epidural or spinal. Whereas upper limb, like to do awake in a very high risk patient, you need to know how to block the arm. And axillary block comes very handy. If you've got somebody, I remember doing a patient who had been transferred from a cath lab with a false aneurysm of the brachial artery. And he had just had an acute MI, gone to for an angioplasty and came back with a false aneurysm of the brachial artery. To do such patients with something like block, you are reducing the morbidity and mortality of the patient. So what are you blocking here? Just dermatomes were shown by Sunita, but it's more than dermatomes. It's the myotomes and osteotomes as well. So start with osteotomes. So if you see, that's the orange bit are the radial innervation. The purple bit is the musculocutaneous. So you can block right up from there down with an axillary block all the bones. As far as muscles are concerned, that's biceps, which is musculocutaneous. That's triceps, which is radius. So you can block from there down all the things with an axillary block. Now here, dermatomes, which was shown, what the medial cutaneous nerve of forearm and the medial cutaneous of arm, or the intercostobrachial nerve, which sometimes forms part of it, these come from the medial cord, and these might be missed when you're doing an axillary block. But you can have, you can just infiltrate just over the ulnar nerve and subcutaneously over that to get these two nerves. So that way, you can block from there everything with an axillary block. And with the safety profile, I don't think you don't need to do anything else. So infraclavicular block, which is an alternative, it's good for catheters, but I would never do it if it's just for procedures, like for operative procedures. So when you've done the block, the first thing you have to do before you give it to surgeons is to make sure your block is working. So how do you assess your blocks? You do both sensory as well as motor. For median nerve, you look at the thenar eminence. For ulnar nerve, you test the hypothenar eminence. For radial, you test just opposite the thenar eminence on the dorsal aspect. And for musculocutaneous, you test the lateral aspect of the forearm. So all 4 nerves you can test. The medial cutaneous nerve of forearm, and medial cutaneous nerve of arm. All nerves you can test with this. As far as muscle innervation is concerned, for median nerve, you look for the flexion of the fingers. So flexing fingers. Grip is for median nerve. For ulnar nerve, it's ulnar deviation or flexion of the little finger. For radial, it's the extension of the wrist. And for musculocutaneous, it's flexion of the elbow. So all 4 nerves you can test and make sure your block is working. And if it fails, you can do several things. You can do the block again. You can see the nerves a little bit distally where you put, because once you have put lots of local anesthetic, the nerves might not be seen very well. So you can do distally. You can, but be aware that like you're not exceeding the safe dose of local anesthetic. I'll show you some of the distal blocks you can do, radial, median. If it's just cutaneous branches, like the medial cutaneous nerve of forearm, or lateral cutaneous nerve, which is the terminal branch of musculocutaneous nerve. If you are doing something like, say, fixing the radius with a plate or something like that, the surgeon is going to go through the skin, which is the lateral cutaneous nerve of arm, whereas inside it's median nerve, and if median nerve is blocked very well, then you can do the surgery. But when the surgeon tests, the surgeon will test for lateral cutaneous nerve forearm and say like the block is not working. What you just need to do is ask him to infiltrate. Inside is all blocked if your median nerve is blocked. Again, like you could use analgesics or give general anesthesia. And as I said, like at worst, it's like doing the case under general anesthesia, which some of your peers who don't do blocks might be doing. What local anesthetic to use? It depends on how long you want the block to work. If you want block to last for 18, 24 hours, you are going to use something like bupivacaine, ropivacaine, levobupivacaine. If you want a shorter duration, you're going to use something like lignocaine or prilocaine. I use prilocaine a lot for axillary blocks. And I tend to use selective 1 or 2 nerve blockade with a longer acting local anesthetic. So I'll see where my bones are innervated, what bones the procedure, the innervation of that part of the bone, and block that with a longer acting local anesthetic like ropivacaine, 0.75 or 0.6% ropivacaine, and rest of the 3 nerves I'll block with 1% prilocaine. What I can do as well is like I can do for all 4 nerves with 1% prilocaine and block the radial nerve or median nerve distally with something like a ropivacaine, or I like doing that because that way like the function as such is better. In 4 hours, patient can move the elbow but still pain-free. So I'll show you these 4 distal nerve blocks as well, radial in the lower arm, median at the elbow, median in lower forearm, and ulnar in lower forearm. So the radial nerve in lower arm will look something like this. And if you see here, that's the bone, okay? The triceps muscle, which is deep and which is posterior. You've got biceps, this is brachialis muscle, which is deep and anterior to triceps. And there is biceps here, which is superficial and anterior to brachialis. So that knowledge of anatomy, you can then see how the muscles are distributed. Median nerve, this is in forearm. That's flexor digitorum superficialis and flexor digitorum profundus, and it's sandwiched between those two muscles. Ulnar nerve goes with the ulnar artery in the lower forearm. It's just under flexor carpi ulnaris muscle and over flexor digitorum profundus as well. Finally, I'll just talk a little bit about, I said like I don't need to do I hardly do infraclavicular blocks, but it's a good skill to have if you want to put catheters. And your probe will be something like that, parasagittal, just lateral to the coracoid process. But there are umpteen number of approaches mentioned about infraclavicular. Every possible oblique or transverse orientation of the probe is possible. This with that parasagittal sort of like orientation, what you're seeing is this cut section, and in that cut section, really this probe, you would like it to be slightly caudal, and you will see something like that of a section. And then you will see pectoralis major, which I showed you earlier, pectoralis major, pectoralis minor, the artery is capillate, vein is caudal, and then the three nerves which are distributed around the artery. High up in the axilla, they are all lateral. Lower down, they are seen as lateral cord lateral to the artery, posterior cord posterior to the artery, and medial cord in between the artery and the vein. And that's how it looks here. So I'll just show you the bigger image of that. So that's pectoralis major, pectoralis minor, axillary artery. That's your lateral cord, that's your posterior cord, and the medial cord in between the two. So if you want to say these are a bunch of grapes, you can say that. And in a bunch of grapes, what you see is the black things are the fascicles and the white things are connective tissue. What you're trying to do is never to go into the fascicles. That's where you get nerve injury. So if you can start learning the boundaries of these by looking at it several times, what will happen in due course, you will know not to violate that boundary. And when you don't violate the boundary, Dr. Gaur said about the glide sign, but when you don't violate the boundary and inject, the nerve will be pushed away. If you are in the nerve and you inject, the nerve will swell up. That's how you identify the intraneural injection. If it swells up, most of the time nothing happens. But make sure you don't inject loads and loads of local anesthetic in it. Just at times give 1 ml, and if that goes, you know you are inside, pull your needle back and inject it outside. Okay, so that's my sort of like presentation. I'll go and demonstrate now, start with axillary and show you a few of the other things, and then we will take questions. Okay, so what I'm going to do, first check that I've got my machine set up properly. So I'm looking at, can you show, so what I'm going to do, Vipul, just show the nerve. I'm going to look at the right side screen to make sure that it's set on nerve. Then the HFL stands for high frequency linear probe. So I want it to be on a high frequency linear probe. And then lower down, Nichajo. That resolution thing, I want it to be set on resolution. You can change it to general and penetration, 3 things, which changes the frequency, but I want it on resolution because I'm going to see the superficial structures here. Okay, I'll show you. And then I'm going to position patient's arm. Now, I'm assuming that I've checked everything, the sign-in and all done. I want the arm abducted, laterally rotated at shoulder, abducted to 90 degree, and then flexed at the elbow. Okay. With this position, a little bit more abduction or a little bit less abduction doesn't bother me. But I'm looking here for the biceps and the triceps muscle. I can see sort of like the groove in between. In the past, like I used to feel for the axillary artery, just making sure, and then I could make a line sort of like going from the midpoint. I've got some idea of how deep and this by feeling. But now for the purpose of this demonstration, I'm going to place this where I think the artery should be. So I go place it on that, and I'm expecting to see the artery right in the middle of the screen. It's slightly to that, so I'll get it in the middle. So you can see that. What I'm going to do now is use that part maneuver to show you how I'm looking for different structures. So here my point of reference for axillary block is axillary artery. So that's my guide. I'll relate every other structure to axillary artery. So I'm going to release the pressure, and you can see the vein which is posterior and superficial to the axillary artery coming in the view. I put a little bit more pressure, it goes out of view. Okay? So you have to make sure you know where the veins are. I can see only one vein. I'm trying to look for whether there are other veins around, but I can only look for one vein, which is I will try and talk in terms of clock face, which is here about 1 o'clock to the artery. Okay? So having done that, the next thing I want to do is try and scan up and down. Okay? So I'm going down a little bit. I'm seeing the structures I need to. I'll talk through those structures in a minute. I'm going up at the moment. Okay. Okay. So I've done my sort of like, and I've been sliding up and down while I'm doing that to get an idea. I want to go as high as possible. That way, like, I'm more likely not to miss this medial cutaneous nerve forearm, which runs with ulnar nerve, and medial cutaneous nerve of arm. Come from the medial cord, but they are not far off from the medial from the ulnar nerve. So that's why I want to, and that's what I've done. I've gone right up into the axilla here, if you could see that. Yeah, you're seeing the probe very well, isn't it? Again, like the probe handling and all is very important, how you're doing that. Next thing I'll try and do is use my rotation and tilt to make sure I can see the structures well. Okay, so I've sort of like done my assessment, and I'll talk you through that assessment. So median nerve here can be seen on 12 o'clock position. Yeah, if you see that, it's like with a tilt, quite a bit of tilt, like you can still see it all the time. Yeah, median nerve, which is just or anterior to the vein. Yeah, and superficial to the artery or medial to the artery, and you can see it nicely. And Vipul is nicely showing you the border of the nerve. So you can see the muscle, biceps on the left, or anteriorly as you would call it, okay? And you can see the latissimus dorsi here actually. And I'll scan down and show you why it is latissimus dorsi and not triceps. But that's what latissimus dorsi looks like, okay? So that you've seen. Ulnar nerve is further from the a vein. So if you see, and it's sometimes in one particular view, you can't see all the three nerves. And somebody asked that question, and the reason is they don't run parallel. So if you are trying to cut these nerves in a cross section in a perpendicular manner, you need a different tilt for each of the nerves. So if you see the ulnar nerve, just the lateral, that's the ulnar nerve, and it's not that well seen as the median nerve, but once you start seeing quite a few, and with pressure and all, they become prominent. So, but see, the gap there is so less, the triangular shape. So if you put a little bit of local anesthetic, 3 to 5 ml, that will get block the ulnar nerve. And the radial nerve is between axillary artery and the vein, posterior or deep to the axillary vein. So so if I tilt it quite a bit, and you see the capillate tilt because it's going posteriorly, the angle of the probe is facing capillate direction, and that way you can see the radial nerve much better. Yeah, can you reduce the depth, and we'll just show. Even reducing it further, see, it's like 1.5 centimeters deep, and you might be able to see these structures I'm talking about even better. Okay, so now I was talking about this being latissimus dorsi. As I go down, you will see that it changes into. So from that being the insertion of latissimus dorsi, goes down, that comes, it changes, you can see a bit of triceps and latissimus there, and then that's triceps muscle. So sliding and all gives you that opportunity to look at the muscles. So that's most of axillary block. For radial nerve in the forearm, I want the arm on patient's tummy or chest, and I'm looking for surface landmarks here, the biceps. Underneath the biceps is brachialis, and then the triceps there. So your radial nerve has gone posteriorly, and somewhere in the middle it starts hooking and coming between brachialis and triceps, and then brachioradialis and triceps. Somewhere there it becomes superficial. For in this region, I should see the nerve underneath. So like what I'll do is start scanning bang in the middle there. So again, like what I'll try and do is make sure I know which side is which. So here, that side I want to keep lateral, so I'm just rotating the beam. This is not how I'll stand. My machine will be that side, and I'll be standing in a different position, but for the demonstration here, I'll be a little bit awkward. So and that's humerus, you can see. Increase the depth. Start so you can see humerus nicely with hyperechoic shadow, and then you can see anechoic region underneath. And if you see just to 12 o'clock, 11 o'clock position, you can see the radial nerve there. And I can scan it down, right? And the triceps here is posteriorly, which means to your right, and the brachialis muscle is sandwiched between brachialis and the triceps muscle. I can go down and decide where I want to put, right from there up anywhere, and I have to tilt and use pressure and rotate to get the best view. But you can see that I've identified it in between the muscles. So all the nerves going through the muscles, you don't need to be very close to the nerve. You just need to inject in between the muscles. It's an intermuscular space. If you inject few mLs in the intermuscular space, so in this particular case, that white shadow, I'll try and just put local anesthetic where the white shadow is and white line. And what I should see is the two muscles separating and local anesthetic bathing the nerve. So that was radial nerve.
Okay, Prashant, we need to move. Yeah.
Yeah, okay. So shall I quickly show, I missed musculocutaneous, but I'll just show you the nerves. Here the brachial artery and the nerve is a triangular shadow just next to it is the median nerve. For median nerve in the, you see the median nerve there, and the muscle above it is digitorum superficially, muscle below it is profundus, and you can see radial artery coming in the weave. Yeah, and the nerve is just a small triangular shadow there, just next to it, between, just above the vein, which is, I'll quickly show you the musculocutaneous nerve, and while I'm doing that, you can think about questions if you have. So as you scan from, so what you see there is the musculocutaneous, but like I could have shown you earlier, as you trace biceps, it lies between biceps muscle and the brachioradialis muscle. Coracobrachialis muscle, correct. Yeah, so you can see that. And again, like same thing, when you put in between the muscles, it gets blocked. No. So if you have any questions on upper limb blocks, we can answer those.
Okay. And then before going there, how many of us really want hands-on experience? Please raise your hands. Don't feel shy. Okay, so 1, 2, 3, 4, 5, 6. So do you think that 2 hours is enough for that hands-on towards the end of the day? Is that all right? Okay, that's very good. Yeah.
Hi, Nikhil Desai from Royal Wolverhampton NHS Trust. I've got actually 3 questions for you. Musculocutaneous nerve, I do a hand list, and always, most of the time, I find it very difficult. And I use nerve stimulator sometimes, even despite that. So what I do is, I just infiltrate around 4 mils in between the 2 muscles. Is that a right way to do if you can't find? Other question is, sometimes radial nerve can be confused with a post-cystic enhancement on ultrasound, in which case what you need to do. Third is, one of my consultant colleague is to do out-of-plane approach for ulnar nerve, because it's quite far, and to get a needle in plane approach is very difficult. What's your experience regarding that?
Okay, one question at a time. Musculocutaneous. What I would say is it's not difficult to see. So you can track it. It's usually deep and anterior between, as we said, like coracobrachialis muscle and biceps. So you could see the biceps muscle, just follow it and can see in between. So I'll try and see it most of the time, like, and only block when you see it. If you really can't, and if you're doing, say, forearm surgery or hand surgery, it's not important for hand surgery. For forearm surgery, it's the lateral cutaneous nerve forearm, so you can ask surgeon to infiltrate in that case. And if you are doing something like lower arm, where you need the muscle as well as the bone, which is innervated by musculocutaneous, then if you don't see it, you might be thinking of doing infraclavicular in that case. But I haven't really had problem seeing it. I could just try looking it in between the two. Yeah. But if you see, definitely see biceps muscle can make the lower boundary of it, then infiltrating just underneath the biceps muscle which will be in between biceps and coracobrachialis, you might get that. Okay? Your radial nerve being confused for post-cystic enhancement. Post-cystic enhancement is always at 6 o'clock. People talk about radial being at 6 o'clock. I rarely found it at 6 o'clock. It invariably, majority of cases, it's at 5 o'clock. So you're trying to look for two things, isn't it? As a cystic, post-cystic enhancement, which is so much different actually from the nerve. It's sort of like those reverberations which go down, whereas the nerve you saw is like bunch of grapes, as some call it. So that's a side. If you don't see it at all, people say like you don't see it in 20-30% of cases, radial artery. What I think, it's a small triangular space, so if you put 5 or 10 ml in that space, you invariably get radial artery. Ulnar nerve is very superficial. Yes, it is difficult to go from the other end to reach the ulnar nerve. One of the things that can be done is hydrodissection. So you just use either local anesthetic. I would prefer to use something else like saline. So with that, you can separate anything and go anywhere. So that's the problem. So like you saw, the vein was there. I would have gone above the vein in that particular center and just put it above the vein. Yeah, put on the other side of the vein in between the fascia and the vein. That does catch ulnar nerve, and not only ulnar nerve, it will catch medial cutaneous nerve of forearm and sometimes even medial cutaneous nerve of arm, which we can't differentiate really on the scan because they are very small structures.
Yeah. Excellent. Next question, please. Any other question? Yeah.
Excuse me. I'm Subramanian Ramani from Northampton. I work along with Dr. Kakodkar. If Dr. Kakodkar doesn't mind, can I make a couple of comments about the ulnar nerve? You were asking about ulnar nerve approach, out of plane approach. I never need to use out of plane approach for ulnar nerve. And I can understand what you're saying because it can be a bit tricky because you're trying to do medial nerve and radial nerve because the hand is like that. For ulnar nerve, I use the position where I place the arm like this and then I trace the ulnar artery over here and then I trace it distally and I wait for the ulnar nerve to diverge from the ulnar artery.
Axillary approach.
Axillary approach, sorry, that's mine.
That's okay. Yeah, but then thank you for letting us know new technique. Any other question? Or someone, yeah, Ekta, yes, please. Speak loud.
If you're not able to see a nerve, will you still go and put local anesthesia? Because the whole idea of ultrasound is that you're seeing it. And it's not a facial plane that you can just go and give local anesthesia.
At the same time, you know the whole neurovascular bundle is around the artery. Neural bundle, as you could call. In the past, what we used to do, with landmark technique, we used to put it around the artery. With nerve stimulator, we used to think that we are identifying the nerves, but we know that the distance between the tip of the needle and the nerve is not reliably always very close. So even with peripheral nerve stimulators, what we were doing was putting local anesthetic around the artery. There is enough cadaveric and other MRI type studies to say that like it's a small space. If you get local anesthetic in the space, so if you don't see a nerve, say radial is one which is difficult to see. If you don't see it, as in 20% patients, why not put a little bit posterior to the artery, or which was transarterial approach in the past, and get the block working rather than saying I don't see, I don't put, and definitely won't have a block. So that's sort of like, at the same time, you have to make sure you're not putting it in an unnecessary place. So I wouldn't just put it somewhere where radial cannot be there. So you either will be wasting the local anesthetic, or if you're putting somewhere like where the vessel is, you might be causing other harm.
Any questions regarding supraclavicular? Yeah, Ekta. Yeah, but then when nerve is not there, you won't get nerve stimulator. I'll tell you, I'll give you an answer. Can I have that probe, please? And some jelly, please, here. just here. Okay, so if nerve is not there, it is rare, but then yes, that can happen, all right? So confirm the side of probe, okay, that's how I do. Place the probe onto the wrist, okay? You can see the cross-section of all nerves and tendons over there. Tendons are fibular pattern, nerves are fascicular pattern, and then start moving up. Okay, when you move up, you can see median nerve there. Can you see that? Right in the center like diamond, okay? And then you can't go wrong then. Then move laterally, you can see radial nerve there. And then, can you see that? Radial artery and radial nerve there. And then come back again to median nerve there. And then go ulnar side. And then you will see ulnar nerve and ulnar artery. Okay, in case, can you see that? It's going. So that is what is dynamic imaging about. When you do dynamic imaging, you can see these nerves very clearly. Yes, if they are not there, like internal jugular vein is not there in 4% of the cases, okay, so then that's okay. But then otherwise, like Prashant mentioned, if you are not able to see it, just place a facial plane, local anesthetics, and that will assist. Patient is lucky. Otherwise, give him tocal anesthetics. Okay. Any questions regarding supraclavicular? Yes, please carry on. Axillary? Yeah. Not supraclavicular. All right. Okay. Axillary, you can ask. Yeah. Ask. Go ahead. Yes. Okay. Because we are just. Tea is getting cold.
In axillary root, if you can't find all the three branches, it means median, ulnar, radial. In older days, when we don't have ultrasound, you remember we used to do transfixation as well as periarterial, isn't it? If you can't find all the terminal branches, is it okay with the help of ultrasound we deposit the drugs around the artery? What is your take on that?
Can you introduce yourself, please?
I am Dr. Dalang from AIIMS, New Delhi.
Yeah, the same thing what I've said, like you could put local anesthetic around the artery, but you have to make a judgment as to where we would put it, how much you would put it. If you see a couple of these nerves, then you wouldn't put more local anesthetic in the same place. You would go and try and get the local anesthetic in a different place where the third nerve might be.
Okay, so now because there are no questions about supraclavicular, I'll just show you quickly one block. Okay, so I'm standing on head end of the patient. All right, patient is looking on the other side. Okay, and then we'll break for tea, and then we'll crack on to the next. I confirm the side of probe. Can I have is it gone? Okay. Sonocytes are very lucky people today.
Can we have
we don't have, anyway, I'm showing you probe placement by the time. So you place the probe like this, okay, over there, and then you try to locate the artery over there, okay. Can you see that artery over there? And that is subclavian artery, and around that you can see brachial plexus there. All right. Now just tilt your probe by about 40 degree or 60 degree. So all those nerves there, yeah, that bunch over there is responsible for shoulder block. Okay. You just put in local anesthetic. So here you can see that. So that is supraclavicular brachial plexus there. Even in very obese patient, when you tilt your probe like that, that is the brachial plexus there, which is responsible for shoulder. Now here, instead of vertebral artery, you get a shadow of subclavian artery over there, okay? Very simple, very superficial, 1 to 2 centimeter, even in very obese patients. So see supraclavicular brachial plexus there, and then just tilt the probe there, and that is the, and then what happens, because even in our book, we have, pointer please, even in our book, we have shown it incorrectly. Interscalene brachial plexus block, interscalene arrangement of the brachial plexus doesn't lie here. Basically, our seniors, they used to put a needle from here, but the needle tip used to go there in the base. So this is a nook of the neck and shoulder, nook and corner, nook in the neck and shoulder. So that is the brachial plexus there, okay? And then you just tilt your probe like that, and that is the brachial plexus responsible for shoulder. All right? Always use colored Doppler before you do any block. Always rule out the presence of artery or vein in the trajectory of needle. Try to manipulate your needle accordingly if you can't get rid of artery or vein. I'm basically a very practical person. I don't know too much of theory. I keep learning from you guys theory thing, so that's how I remember. But then I do practically very successful, and that's the reason why I'm in England as well, because I think that I'm not bad in my techniques. So I'll just show you that what you need to do, not to miss musculocutaneous or to do whatever you do. All right, when you are putting an axillary brachial plexus block for acute pain, then or anesthetics, then what you want is basically to block all three. Okay, so what you do simple thing. You have a tourniquet placed here, venous tourniquet, which we use for making our veins prominent. Okay. After that, you scan. Before that, you're not tightening up the tourniquet. All right, you leave it loose. Come from the side of probe. I always keep this side away from me. Okay, so that when needle goes in there, and then I locate the axillary artery there.
Atul,
Okay.
it's not set up for.
Oh, all right. Oh, sorry. So how we can connect this machine?
Yeah, connecting now,
All right,
connected.
okay.
Yeah.
So what I do then I confirm the side of probe. I always keep that side away from me. I never do with my fingers, because otherwise you are having jelly on your finger. And then I apply tourniquet here. Okay. It is not applied yet. It is just placed. After that, I go further up to track all these nerves there, and then they disappear. It's all black, so that means that is upper limit. Okay. And then I come back, and then I try to see the musculocutaneous there, which is very easy. You can see it there, it's going there, and then it joins there. Can you see that pearl-like structure there?
Yeah.
It's going to go in that groove. Okay, so that means that there you can see all fascias connected to each other. Can you see that? I come back here, I again
Pointer,
see veins.
pointer.
Pointer.
Where's the pointer?
I come back here, I again see the vein, presence of vein. Okay, Vipul has got pointer. All right, don't worry. So Prashant can show with hand. Prashant over there. Okay, so the axillary artery is seen there. Okay, that's the musculocutaneous. Okay, so what I do now, I take my needle from here after applying some local anesthetics. I apply local anesthetics, then make that tourniquet tight. Okay, so what is happening now, when I deposit local anesthetics, I have stopped the runoff of the local anesthetics distally. Okay, and I deposit at 12 o'clock position, 10 mils or 8 mils, depending on the spread. Then I go on to the 6 o'clock position or 7 o'clock position onto the, or 5 o'clock position onto the artery, deposit 8 mils or 10 mils, depending upon the dissection. Then I can see all nerves floating in that local anesthetics. Okay. After that, I take my probe slightly distally and I milk it up. Okay, like that. I apply a little pressure and then I go up. So I spread that local anesthetic centrally. Okay, so it is going more central. And then that local anesthetic takes care of everything. Okay, that local anesthetics base everything. So no need to change anything, just 6 o'clock, 12 o'clock, deposit local anesthetics, has a tourniquet there, and then so that there is no runoff. After 10 or 15 minutes, you can remove your tourniquet, and then patient is fine. Okay, thank you. Sorry, Prashant.
No, that's all right. If you saw, the orientation of probe is exactly opposite of mine. Anterior aspect was seen on the right-hand side here. Mine was on the left-hand side. Exactly what Dr. Gaur does. My orientation is such that the anterior is on the right-hand side. But lot of images and videos, you will see anterior aspect on the left-hand side. And that's why, for demonstration, not to confuse you, I changed my way of doing it. But whatever you do, you need to know which side it is.
This is Info Media Prime Slot Network, and you're watching Prime. Your voice, your channel.